About posterior uveitis. As you know, uvea is the middle coat of the eye. Uveitis is inflammation of the middle coat of the eye, as well as adjacent structure like retina, optic nerve, and vitreous. Posterior uveitis is the second most common uveitic entity in India in particular, and it is 25% of the uveitis in India is posterior uveitis. The most common form of uveitis is anterior uveitis, that is around 35%. 30%, and 30% is intermediate uveitis. Posterior uveitis can often be challenging due to its protein manifestation, non-classic presentation, and most of the times it involves the posterior pole and can cause mild to moderate, not only moderate to severe visual morbidity. Investigations in posterior uveitis or approach to the posterior uveitis needs a good clinical history, good ophthalmic examination, and ancillary testing, which includes fundus photography, fundus fluorescent angiogram, indocyanine green angiogram, optical coherence tomography, and now optical coherence tomographic angiogram, which we call OCTA. We need to find out the cause of the uveitis, and that is done by laboratory investigations as well as radiological investigations. Laboratory investigations for tuberculosis, toxoplasmosis, syphilis, and non-infectious etiology like sarcoid basettes is important. Management of the non-infectious uveitis is corticosteroid as the principal modality, and then followed by the immunosuppressive agents. Now biologics has come, and particularly it is used in Basett's disease. Infectious uveitis should be treated with according to the infectious etiology. In case of tuberculosis, posterior uveitis, we treat with the anti-tubercular treatment. And in case of toxoplasma, anti-toxoplasma medication is given. And in case of syphilis, anti-syphilitic medication is given. In all these cases, once you put the patients on anti-infective agents, you may need to give systemic steroid along with it to control the inflammatory component of the disease. Patients of the posterior uveitis needs very close and detailed evaluation and careful observation, not only to find out that infectious versus non-infectious, active versus non-active uveitis or healed uveitis, and most important, to find out the complications like choroidal neovascular membrane, which can mimic recurrence of uveitis, cystoid macular edema, as well as epiretinal membrane formation. So today's talk will be various aspects of posterior uveitis will be discussed. I'll be discussing approach to the posterior uveitis. Dr. Parthapratim will be talking on update on management of uveitis. Dr. Natarajan will be talking on vitreostomy surgery for posterior uveitis. And finally, intraocular toxocara would be described by, told by Dr. Huan Kuang. So let me start with my talk, approach in the posterior uveitis. We'll keep the questions at the end of the session so that the time frame is kept in properly. Okay, let me share my screen. Am I audible? Am I audible? My screen is seen?
Yes. Yes. We can.
Yes, let's see.
Good morning. I'll be talking on approach to the posterior uveitis. And first, I'll be talking on algorithm of diagnosis and management of a case of choroiditis. How do I do it? It's not textbook presentation. It is a experience of mine over 35 years looking into the uveitis cases. First question I ask, is it a choroiditis or anything else? And you'll be surprised that many conditions can mimic choroiditis. And this is a case. You can see in the posterior pole, there is yellowish white lesion, ill-defined margin, and you might think that this is a choroiditis. But if you do a fundus fluorescent angiogram, you can see the point leaks are there all over the posterior pole, and which increases in size and intensity as the angiogram goes to the late phase of the disease. It's not posterior uveitis. It is indeed multiple leaks CSR which mimicked posterior uveitis. Second case is also interesting, is a 57-year-old lady, painless gradual dimness of vision for 9 months. And this was thought to be a tubercular choroiditis and was put on antitubercular treatment. But if you look carefully, you can see the yellowish lesions, and in between the yellowish lesion, white dots are seen. These dots are, black dots are seen. This is leopard skin-like appearance, and this is not posterior uveitis. We did a final aspiration biopsy, which is the last resort, and we find out that there is within the necrotic background, we can see the large lymphoma cells. This is a hyperchromatic nuclei with the scanty cytoplasm. This is indeed intraocular lymphoma, but not posterior uveitis. Here is again a case of patients with a yellowish white lesion at the periphery. But if you look carefully, there's just choroidal stria is seen. And this is not posterior uveitis. This is posterior scleritis. And if you do an ultrasound, we will find the sclerochoroidal thickening. And you can see that after the treatment, there is a marked resolution of the lesion, and fundus has become almost normal. So it is a posterior scleritis which mimicked choroiditis. So conditions, to summarize, conditions that can mimic choroiditis is multiple leak CSR, posterior scleritis, age-related macular degeneration, both dry and wet type, and last but not the least, vitreoretinal lymphoma. The first question to be answered in posterior uveitis, is it a retinitis or is it a choroiditis? Or it is a retinochoroiditis or chorioretinitis? If you look at this picture, this might be confusion whether it is a retinitis or choroiditis, but if you look carefully, you will be finding that this is a whitish patch, not an yellowish patch, and there is a ill-defined margin, and most important, blood vessels are not seen over the lesion. It's associated with the retinal edema overlying vitreous haze. So this is retinitis. In contrast, if you look this case, where is the yellowish nodular lesion is seen, and here you can see the difference. Blood vessels are going over it. And if you look at that one, you will see that there is a yellowish patch, not a whitish patch, and the ill-defined margin, original vessels can be seen over it. So that is choroiditis, not an retinitis. Next is question, is it a focal, multifocal, or disseminated? Focal choroiditis can be macular, where it can be vision threatening and you need urgent treatment, where it can be extramacular, and there also you need to investigate for the cause and treat accordingly. When you see a focal retinochoroiditis with localized vitreous haze, the most common differential diagnosis would be toxoplasmic retinochoroiditis. And you should give anti-toxoplasma treatment after investigating for toxoplasma. And here you get the ELISA for toxoplasma, as I mentioned to you, and then you can see the marked resolution of the lesions with a scarring after anti-toxoplasma treatment. If we see a choroiditis with geographic border, as is seen over here, and you should think of serpiginous choroiditis. Diagnosis is serpiginous choroiditis, which has got a very classic picture of geographic border with choroiditis. Here is another example which can mimic serpiginous choroiditis. Instead of yellowish color, you can see that the pinkish color margins are also irregular, is the other eye. But if you do an ultrasound, you will see that the high reflective echoes are seen. So what could be the diagnosis here now? If you do a CT scan, it showed the bony lesions in the choroid. So it is not a choroiditis, it's a choroidal osteoma. So there could be multiple choroiditis, and here the differential diagnosis to be kept is APAN PP, what we call acute posterior multifocal placoid pigment epitheliopathy, serpiginous choroiditis, amphigenous choroiditis, sarcoid, or TB. Multifocal serpiginous choroiditis now thought to be tubercular origin based on the various clinical tests and as well as clinical research, as well as some histopathological study done in selected cases. So how do you investigate? The most common thing is to ideal approach to do an ancillary test, imaging method, imaging modalities. This should be fundus photo documentation with autofluorescence. And then we do the FFA and ICG as required, and optical coherence tomography. Swept source optical coherence tomography or EDI OCT is better, and OCTA if you are available, if it's available. And then how do you investigate? You should rule out TB, sarcoid, and syphilis. You do the X-ray test, HRCT test, Mantoux test, which is called PPD, purified protein derivative test, quantiferon TB gold test, serum angiotensin converting enzyme for sarcoidosis, VDRL TPHA for syphilis. So fundus autofluorescence plays a crucial role in diagnosis of choroiditis, particularly the stage of the inflammation, whether it's an active or healed. It's an imaging method that allows topographic mapping of lipofuscin distribution in the retinal pigment epithelial cell monolayer as well as of other fluorophores that may occur with the disease in the outer retina and the subneurosensory space. I'll show an example. So I do autofluorescence routinely in all choroiditis case, active or healed. It can distinguish active from healed lesion, can be used for follow-up. Here is an example of active as well as the healed choroiditis mixture. You can blue arrow sees the active choroiditis, and corresponding you can see the hyper autofluorescence in the blue arrows. And the healed lesions here is yellow orange arrow showing that the hypo autofluorescence lesion. So you can distinguish active from healed lesion. I do FFA in all cases of active choroiditis except in toxoplasmic retinochoroiditis. Here is an example of choroiditis. You can see yellowish round or yellowish oval lesion. And you can see the fundus fluorescent angiogram early stage. You don't see the lesions, hypofluorescence lesion. As the FFA goes into the late phases, you can see that there is a ring of fire appearance. Central area is hypofluorescence surrounded by ring of fire. This is typical of tubercular choroiditis. You can see a placoid lesion in the choroid, and if you do angiogram, fluorescent angiogram, you see the hypofluorescence lesions, which later on the whole lesions becomes hyperfluorescent. And this is APMPP, acute posterior multifocal placoid pigment epitheliopathy. Diagnosis can be made by FFA only. Here is an in-between, is the amphigenous choroiditis. Here you can see the fundus fluorescent angiogram, small lesions with the geographic border, and central area is hypofluorescent. If we look at this is amphigenous choroiditis. If you look at the serpiginous choroiditis, where you will be seeing the active ages is hyperfluorescent, and the healed stages, you will be seeing the hypofluorescence. So hypofluorescence with the hyperfluorescent margin is often seen in serpiginous choroiditis. ICGA, when do you require it? It's important to particularly see the extent of the lesion, particularly when there is a close to the macular area. It is a more sensitive than fluorescent angiogram. Choroidal lesions is much better seen, and particularly CNVM in the differentiated areas of the scar. There is minimal or no staining of the scar, unlike FFA. Here is an example. You can see the fluorescent angiogram showed hyperfluorescence lesion, but there are some lesions which are missed over the fluorescent angiogram. And if you do an ICG, you can see the lesions is much larger in size, as well as the new lesions are seen on ICG, which has been missed by fundus fluorescent angiogram. So ICG is very important in diagnosing and managing the extent of the lesion. Here is an example of choroidal lesions, and you can see the peripapillary lesions, which is not picked up by the fluorescent angiogram in the mid or late phase. And here you can see the ICG showed hypofluorescence, indicating the diagnosis of the lesions with extent of the margin. Here you can see the fundus looks normal. You don't see the lesions over here. But if you do the fundus fluorescent angiogram, you can see the wreath-like dot hyperfluorescence seen over the posterior fold. And ICG showed numerous hypofluorescent spots, indicating that this is a multiple evanescent white dot syndrome, where you can see the white dots in the fluorescent angiogram, as well white dots which might be evanescent, but the fluorescent angiogram picks up such white dot syndrome, and ICG does it much better. So what is very important in any case of suspicion of CNVM, optical coherence tomography is of paramount importance. So when there is a recent reduction in the vision, metamorphosia with no active inflammation, you should think of choroidal neovascular membrane, which is picked up by the OCT, is the type 2 choroidal neovascular membrane. Here is another example of choroidal neovascular membrane, which can be very subtle, so we need to be very mindful of the choroidal lesion, choroidal neovascular membrane. OCT angiogram is the new modality, novel technique to detect abnormal vasculature. It's a non-invasive technique. Here you can see the first panel shows fundus photograph, doesn't show the choroidal neovascular membrane. Even an autofluorescence doesn't pick up. FFA doesn't pick up the choroidal neovascular membrane. ICG do not show choroidal neovascular membrane. But OCTA, you can see the network of neovascular membrane in the choroidal choriocapillary complex, and you can see that here is also seen the choroidal neovascular membrane. Diffuse choroiditis is another entity which is often immunogenic in origin, and this immune-mediated choroidal lesions. You can see some large choroidal mass or abscess, and this can be due to the tuberculosis, very rarely due to nocardia. How do you manage a case of choroiditis? I will be talking the principle of management. First question you need to answer, is it active or healed? And here you are seeing the active serpiginous choroiditis. The margins are raised up, the color is yellow, and there is a indefined margin. If you see the healed lesion, you will be seeing that it has flattened. There is a pigmentation and margins is well defined. Second question, is it infective or non-infective? This is of paramount importance. So if it is a tuberculosis, you have to give anti-tubercular treatment at least for 9 months or even 12 months, and you have to add steroids. If it is a toxoplasmic retinochoroiditis, you have got choice of giving clindamycin 300 milligram 4 times daily for 6 to 8 weeks. And here, steroid has to be started at a gap of 48 to 72 hours. You can use Bactrim DS also. If we see a non-infectious uveitis, oral steroid is chosen in the acute posterior multifocal placoid pigment epitheliopathy. Though it is told that it is spontaneously resolved, I don't take chance. And if there is a serpiginous choroiditis, I add steroid with azathioprine or mycophenolate mofetil and immunosuppressive agents after ruling out TB. If there is a tuberculosis test is positive, like MANTU, quantiferon, HSCT chest, I do the anti-tubercular treatment starting. So if the macula-threatening non-infectious choroiditis, you need to be careful and very prompt. And in such cases, the vision might be threatened. You have to give very high dose of steroid with intravenous methylprednisolone, even 1 gram daily for 3 consecutive days. This should be followed by the oral steroid with or without immunosuppressive agents. So there is an example of a study where they have found intravenous methylprednisolone therapy for acute treatment of serpiginous choroiditis is successful. I'll show an example. Here is the before IVMP. You can see that choroiditis lesion approaching the fovea, and here you can see that the lesions has resolved with well-defined margin. Retinal edema is choroidal edema is gone, and the blood vessels are seen over it clearly. So in conclusion, in choroiditis, clinical judgment, history, the clinical examination is very important. Then come the ancillary tests like FFA, autofluorescence, optical coherence tomography, get the lab workup done, and get treatment started. Not only that, you should periodic ophthalmic checkup to rule out complications like choroidal neovascular membrane, cystoid macular edema, epiretinal membrane. I'll take up the questions at the end. So now few words about retinitis. It's almost always infective. It could be toxoplasma, viral retinitis, rickettsial retinitis. Here is an example of toxoplasmic retinochoroiditis. It's a localized vitreous haze you will be seeing, and this would be appearing as a headlight in the fog, which is the classic appearance. It's the second most common cause of posterior uveitis in India. First cause is tubercular choroiditis, and it can have a retinochoroidal scar with a satellite lesions, or you can be having vasculitis associated with it. We call chyleriasis arterialis. Ocular toxoplasmosis is a clinical diagnosis. ELISA test for toxoplasma is to confirm. Both IgM and IgG also is important. If there is a negative and is an atypical case, PCR of the intraocular fluid can be useful. And do not give posterior subtenon or intravitreal steroid in suspected toxoplasmic retinochoroiditis. It can be diffuse, mimicking diffuse acute retinal necrosis or viral retinitis. In case of HIV infection, you should keep in mind, and you should do in supportive investigations like ELISA for toxoplasma. Even vitreous biopsy may be needed. And you can see the anti-toxoplasma treatment causing the significant resolution of inflammation. One can see that sometimes the dramatic loss of vision with a really serious vision-threatening disease, having an active retinitis lesions in the periphery with wedge-shaped margin, vitritis, retinal vasculitis. This is a condition which should not be missed, and this is actually an acute retinal necrosis, where the molecular biologic test like aqueous polymerase chain reaction from the aqueous or vitreous can be useful, and PCR from herpes group of viruses, herpes simplex, herpes zoster, and cytomegalovirus should be done. And in this case, herpes zoster virus was positive. And you can see that accordingly, intravenous and oral acyclovir was given along with intravitreal ganciclovir, and laser was done to protect the central posterior pole, and you can see that the lesions has all disappeared, retina is attached, and patient gained vision. It's a real emergency in uveitis, as I mentioned. You need a fast-track diagnosis and management. I want to show you another case, 40-year-old immunocompromised male and with gradual dimness of vision. If you look at the picture, you can see that there is a hemorrhage with necrotizing retinitis and small granular dot-like lesion. This is very classic. of CMV retinitis, dry granular appearance with hemorrhage in a necrotizing retinitis. It always occurs in the immunocompromised patient like HIV or organ transplant or on immunosuppression. And this is the typical pizza pie appearance. Another case of HIV, a 40-year-old HIV positive male, sudden gross dimness of vision. And here you can see the lesion starting from the central area and going to the periphery. No vitritis, no vasculitis. What is this? This is a progressive outer retinal necrosis, and you can see the cracked mud appearance as seen in the fundus picture. This is a 34-year-old male, sudden dimness of vision. What is it? You can see the retinal vasculitis as well as the vitreous haze, and this case is a syphilis. If it doesn't fit with your known clinical diagnosis, always think of syphilis. Good history is required, history of exposure, VDRL or RPA, FTAVS or TPHA, the Stepanoma pallidum hemagglutination test is required. I end up with a last case which can be very challenging. This is a 20-year-old man, history of fever, and you can see the corneal spots, retinitis, as well as the vitreous haze. This is a post-fever retinitis where you need to rule out dengue, rickettsia, typhoid, chikungunya. How do you treat it? You should treat the no specific treatment. Treatment of the underlying disease is important, and you can give oral prednisolone, which can cause the reduction of inflammation with improvement of vision. So to summarize, take-home message is to take a good clinical history, which is of paramount importance in choroiditis, retinitis, immunocompetence or immunocompromise, history of fever, PCR of the intraocular fluid, treat the underlying disease. So I talked about choroiditis, retinitis, post-fever retinitis, and then I'll end up here. Thank you very much. And the questions we'll take at the end of all the talks. Okay, you can ask questions. You can ask if there's any questions you are having. Anybody having questions? You can put on your microphone and then you can unmute and can ask questions. I can clarify now itself. Is it clear?
Good morning from Vietnam. Yeah, could you hear me?
Good morning.
Good morning. Okay. I have some patient he have intraocular lymphoma. Yes. And I know that very hard to deal with that because I do everything like I have here with Zeran treatment and I do some injection intravitreal methotrexate. And then I think the situation is will not improve. So do you have any experience about that?
Yeah,
intraocular lymphoma. Thank you.
Lymphoma is often a diagnostic challenge. It can mimic posterior uveitis. It can mimic intermediate uveitis. It can mimic pan uveitis. And here in that case, specific diagnosis requires cytopathologic examination. Cytopathologic examinations include vitreous biopsy, and in case of choroidal lesions, as I showed you one case, even fine needle aspiration biopsy, and need a good cytopathologist to look the cellular morphology. Cellular morphology will be necrosis of the tumor cells and as well as the large lymphoma cells. And the management is intravitreal methotrexate or intravitreal rituximab, and that causes significant resolution of inflammation. But if it involves the CNS, you may need the radiation to the brain. So it is often a challenging diagnosis and the challenging treatment. If the CNS involvement is there, 5-year survival rate is not very good.
Thank you.
Anybody has got any other questions? If not, we'll go to that update on management of posterior uveitis, and this would be taken by Dr. Parthopratim Datta Majumdar, our senior consultant of Shankar Netralaya, uveitis and intraocular inflammation. Dr. Parthopratim, please.
Yeah. So, sir, can you see my slide?
Yeah, I can see your slides. You are audible.
Yeah. So, good morning, everyone, those who are watching this program live here. So, first of all, I would just like to thank the entire APN team and Professor Biswas for giving me this opportunity. So, I'll be talking on update on management of uveitis. So, it has become very easier for me because Dr. Biswas has given the overview of posterior uveitis. So, straightway, what I'll do, I'll just go with the basic principles of treating a case of any uveitis. Though it is mentioned here anterior uveitis, but if you go here, it can be applied to any uveitis. So first is just you understand whether the inflammation is limited only to anterior chamber or to a vitreous or to any particular organ like retina or choroid. The second important thing is you have to understand that when you localize the inflammation. For example, the uveitis is located in anterior chamber. You have to understand, you have to explain whether what are the associated feature, like whether the inflammation is there in vitreous, whether it is there in retina or choroid, whether we can call it posterior or pan-uveitis. So very important to pinpoint the uveitis, what uveitis you are going to treat. If it is anterior uveitis, the treatment will be only with topical steroid. If there is an inflammation in the vitreous, if you see pars plana exudates, then you have to treat it with oral steroid or any other, you may have to give subtenon injection. So it's very important. So to diagnose a case of uveitis and pinpoint the anatomical site, you need to do a dilated examination of the fundus. In other way, comprehensive eye examination is must in all cases of uveitis. So the second point is whether it's a bilateral or unilateral. Take again example of anterior uveitis. If you ask me if it is bilateral, I'll ask the patient what kind of bilateral uveitis it is. Is it simultaneously bilateral or it keeps alternating between the eyes, like one eye and after 2 to 3 months, again the other eye, then I'll think about HLA-B27. Now, if it is unilateral, occurs in a single eye repeatedly, the moment you stop the topical steroid, it again comes back, then we can think of viral uveitis. So this is very important and if it is a bilateral and granulomatous, then you need to rule out the systemic disease. So next is what is the course of the inflammation? So this is very important. Broadly, though the Sun classification has given some descriptor, but broadly we understand that acute and chronic. So you have to differentiate any uveitis with acute and chronic. From history taking, you can pinpoint. For example, the acute patients with acute uveitis, the patient will come to you even after 6 months. They will give you a proper history. Like the patient will tell, yes, during the Christmas time, I had the attack. That means the intensity of the uveitis, the subjective symptoms were so pinpoint and so severe that patient can remember the time. Whereas in chronic patients, the patients with chronic uveitis will give history like, I think it is there for 6 months, and the attendant may tell, no, it is there for 1 year. So the patient won't be able to recognize it from when exactly it started. And after that, you can do an examination and you can find out. So we'll discuss how this acute and chronic can help us in treating, deciding the treatment. The next important thing is degree of inflammation. What is the degree of inflammation inside the eye? For example, you have a patient with fibrinous anterior uveitis, and you have another patient with uveitis with cells occasional or 1+ cells. Now, will you treat both the patients similarly? No. The fibrinous uveitis, you will start aggressive topical steroid, maybe 1 hourly topical steroid you will start, and you will start long-acting cycloplegic like atropine. And in a case patient with uveitis cells 1+, you will start at prednisolone drop maybe 6 times a day, and maybe you will treat with homatropine. So this is how the degree of inflammation decides us to help the inflammation. Now, if you go to the Sun classification, the standardization of the uveitis nomenclature, they have given us two parameters. One is anterior chamber cells, another is posterior chambers, vitreous cells. Now, coming to the anterior uveitis, the improved activity means the two-step decrease in the level of inflammation or decrease to the grade 0, which is termed as a inactive. So main aim of the treatment in anterior uveitis is 0 cells, which is sometimes theoretically possible, but practically it's very difficult to achieve. But our goal should be to achieve the complete remission with 0 cells. Now, when do we call it uveitis worsening? When there is a two-step increase in the level of inflammation, like increasing from anterior chamber cells grade 3 to 4, and broadly the remission is defined as an inactive disease for more than 3 months after discontinuing all treatment. So you have to keep this in mind. We have to aim any kind of uveitis to achieve complete remission. Now, remission is indicated by inactive disease for more than 3 months after you stop all kinds of treatment. So now, having said that, let us go and see what are the armamentarium we have with us. The first one we have is a topical corticosteroid. The second one is we have to assist them is cycloplegic. Then we have the pericular injection, and then we have the oral steroid, and also we can have immunosuppressive and biologics. Now, coming to the topical corticosteroid, there are so many preparations in the market, but which one you should use? So first important is whether the topical steroid is suspension or solution, and what moiety of the corticosteroid preparation is there. So for example, if it is a solution, I give an example here that beta-methazone sodium phosphate is a perfect example of solution. What is the advantage they have? They causes less discomfort, but they have poor penetration. But they requires less patient compliance. So you have a patient whom you suspect that the compliance will be less, and in that case you can choose a solution. Suspensions are the preferred choice for treatment of anterior uveitis because they have better penetration. They though they cause little discomfort because they form the particulate or cake formation, and it can cause foreign body sensation, but it requires more patient compliance. In a study, they have shown that one needs to shake the bottle of a suspension 20 times to achieve the desired level of concentration. So this is very important while prescribing a suspension topical steroid preparation to a patient, that you need to tell the patient about the compliance and you need to instruct the patient to shake the bottle properly. Now we have emulsion, the difluprednate, where instead of aqueous, we use an oil-based preparation. But the problem with this emulsion or the difluprednate, which we have seen, is there is often a high spike of IOP, which is sometimes very difficult to control. So that's why we don't use it regularly in our clinic. So now coming to the moiety of the steroid, if you look here, the italic and the bold the composition of this steroid, you see here, there are broadly the two moieties are there. One is acetate, another is phosphate. Now, if you remember from our basic science knowledge, corneal stroma is hydrophilic, corneal epithelium is lipophilic. Now, what happens? The acetate, it has both lipophilic and hydrophilic moieties, whereas the phosphate has only the hydrophilic moieties. So that's why when we use it, you can see here the anterior chamber concentration after topical use. The drug with acetate moieties, the prednisolone here, reaches the 610 nanogram per milliliter of aqueous, whereas the dexamethasone and betamethasone, remember, these dexamethasone and betamethasone are 6 times more potent than prednisolone. But you see here the anterior chamber concentration, it's much less than the prednisolone. So this is very important to understand that the prednisolone and acetate moiety has a better advantage, and one must use the prednisolone in treating the anterior chamber inflammation. Now coming to the cycloplegic. Cycloplegics are mainly used for the supportive measures. What else they do? They relieve the pain by immobilizing the iris. They prevent the synechia formation, so the risk of complication from the anterior chamber inflammation is less. And most importantly, they stabilize the blood aqueous barrier and help to prevent the further protein leakage. So they hit the basic mechanism there, the basic mechanism of the inflammation. So they have an important role in maintaining or stabilizing the blood aqueous barrier. Now, coming to the periocular steroid, of late the periocular steroid has become less popular because we have now intravitreal steroid. But you have to understand that the periocular injections can be given in broadly two spaces. Like one is subconjunctival space, where I don't know about many of you, but in our center, especially in peripheral setting where we work a lot of community work, there after cataract surgery we inject a short acting steroid. And also in cases of hypertony, when you need to challenge the ciliary process to secrete more aqueous, there what we do, we give long acting steroid preparation like triamcinolone acetonide in cases of hypertony. The next space is the subtenon space. There we inject in cases of anterior uveitis, which is not responding to topical steroid. And in intermediate uveitis, unilateral intermediate uveitis or pars planitis, we give the subtenon injection. And also in cystoid macular edema, we give the injection in the supratemporal quadrant by Nozick's method. So what happened? The drug reaches the retromacular position, and from there they diffuse and enter the vitreous cavity and helps in resolution of the cystoid macular edema. So there are so many preparations for periocular steroid, but we preferably use triamcinolone and acetonide because they are less soluble in water, and that's why they have the depot action. So they can stay for 2 to 4 months. And in cataract surgery, as I said, in cataract surgery, in some procedure to avoid the intraocular inflammation, sometimes we use dexamethasone acetate, which has very less, more water soluble and has very less half-life. So within 7 to 10 days, it disappears from the eye. Now, how to manage a severe case of non-granulomatous uveitis with hypopyon? As you can see here, we start the topical steroid 1 hourly, we give atropine, and with regular interval, we increase the frequency. And then if it is not responding, we use the periocular steroid. And then even if it is not responding, then we can think of using the oral corticosteroid. So now, what are the conditions you need to use oral corticosteroid in anterior uveitis? These are the uveitis cases not responding to topical periocular steroid, bilateral severe anterior chamber inflammation. Rarely you can see the HLA-B27 in elderly patient can have such presentation. Also, sometimes associated with complications like when the anterior uveitis is associated with hypotony or exudative retinal detachment, that time it's a must to give the oral treatment or the systemic therapy, maybe pulse steroid in such conditions. So this is a case scenario. I'll show you a 34 years old lady, present known patient of HLA-B27. And this was the third attack in 1 year. The patient was already on oral methotrexate by the rheumatologist. OD has a severe anterior chamber reaction. You can see here, her IOP was 4 millimeter of mercury and the base corrected visual acuity was 660. Now see what we found in ultrasound. There was a exudative retinal detachment here. So we started the patient on frequent topicals and IVMPs 3 doses followed by oral steroid 60 mg per day. So what lesson I learned from this case is that fundus examination is a must. In case it is very hazy, like in our case, obtain an ultrasound B scan because a surprise may be waiting for you. So don't treat a case of anterior uveitis without examining or without evaluating a fundus. That is very important. So high index of suspicion is required. For example, in these cases, if you see here, it presented like this kind of fluffy exudates. And when we did the cytology of this aqueous aspirate, it revealed that it was a case of diffuse anterior infiltrating retinoblastoma. Obviously, this was a kid. The patient age was 10 years. So you must have high index of suspicion in cases of pediatric uveitis. Now, this is again a 6-year-old hemetropic boy, known patient of JIA. Left eye, he used to complain of redness and ocular pain, and the base corrected visual acuity was 6 by 7.5. And there was recurrent attacks of anterior uveitis 3 months back, but when he presented to us, his anterior chamber was quiet. The patient was on oral methotrexate 7.5 mg as a part of the juvenile idiopathic arthritis treatment initiated by the rheumatologist, and there was no history of posterior segment involvement. And as we know, the posterior segment involvement in JIA is very rare. Now let us see some photographs here. When we examined the child, this was the picture here. You can see here yellowish white like lesion here surrounded by a hollowness here. So when we did a OCT, you can see here there is a breach in the Brooks membrane, and it was a case of inflammatory CNVM. So this is very important to understand that sometimes the GIA can present with idiopathic, even in our idiopathic arthritis, it can present with CNVM. So, and we treated these patients with anti-VEGF and responded dramatically within a month. So corticosteroid, when we talk about corticosteroid, you have to understand that there are some conditions where the chances of steroid response is very high. So you have to be careful. And especially you have to use intravitreal drug very carefully, and dexamethasone or betamethasone very carefully in such patients. So rise of IOP can, with topical use, can occur in 4 to 7 weeks, and systemic use, it can happen anytime. So the take-home message is always check the intraocular pressure when you're starting the patient on any form of steroid. Don't think that this form of steroid or this route of steroid is safer than the other. Patient can develop steroid response with any form and any route of steroid. Be careful while you are treating the children, old age, the myopic patients, patients with diabetes, patients with family history of glaucoma, and high baseline IOP when presenting to your clinic. So that's how, when we talk about a lot of side effects, that's how the immunosuppressives comes into play. We learned about the immunosuppressive from our rheumatology colleague, and now we know that we can use them for non-infectious etiology, the recurrent attacks of anterior uveitis, and the cases which are resistant to corticosteroid. But today, as already there are a lot of discussions in immunosuppressive, I'll go into a much interesting topic, that is TNF alpha blocker. So the TNF alpha blocker is basically a part of biologicals we have now. So TNF alpha is a cytokine produced by the different cells of the immune system, namely the monocytes and macrophages. So these TNF blockers are basically, in common language, we call them biological, but molecular level, these are the cytokine inhibitors. So what they do, for example, this is a cytokine producing gene, they prevent this cytokine release. The cytokines, in other way, they can incite signal, and they can cause biological effects of the inflammation. So these TNF alpha blockers, they prevent this cytokine release. And the common examples of the TNF blockers are infliximab, etanercept, adalimumab, and golimumab. Now, what are the indications when we should choose biological? The first is the Behçet disease. This absolute indication for use is Behçet disease. The second is the cases of JIA, HLA-B27. These are the tricky situations where only on the basis of ocular involvement, one should not use biological, especially in a country like us. And I can understand that many people are there where in their country, the tuberculosis is a endemic, in such situation, I won't advocate using JIA and HLE associated uveitis as a primary indication for starting biological. But in cases where there are systemic association, the joint involvement, the painful arthralgia, in that scenario, one must consult the rheumatologist and start the biological therapy. The relative indications are like resistance cases where immunosuppressive and oral steroids are not working. In such scenario, one must think about biological in sympathetic ophthalmia, Vogt-Koyanagi-Harada disease, necrotizing scleritis, and chronic pars planitis. So now in Shankar Netralaya, we have enough experiences of under the leadership of Dr. Biswas. We have done a lot of many studies where we have found good results in this kind of cases, the resistant cases of various inflammatory onset. So I'll just highlight two cases before I finish. This is one 42-year-old male presented with no HLA-B27 associated uveitis. The patient had a very low IOP, 4 millimeter of mercury. The patient was treated with periocular steroid. The tricot injection was given and was on 1 hourly topical steroid. The patient also complains of backache and stiffness of the knee joint. The examination of the rheumatologist, they found that very painful joints and positive Sober's test. So subsequently, the patient was administered subcutaneous golimumab 50 mg, and the injection was repeated every 4 weeks. So this was the picture. His inflammation subsided, his joint pain vanished, and the IOP improved to 16 millimeter of mercury, which we published later. So this is one scenario, and this is another scenario. A 52 years old lady, known patient of necrotizing scleritis, which was not responding to methotrexate, azathioprine, cyclophosphamide, cyclosporine, and the patient did not get relief. And when she presented to us, her visual acuity was 6/36 and left eye was 6/9. And you can see the active scleritis still there. The problem was the patients had high IOP, the 26 millimeter in the right eye, and left eye it was 45 millimeter. And the patient was already on 3-drug anti-glaucoma medication. And as you can see here, there is already optic disc damage. So our glaucoma colleague wanted to implant the Ahmed glaucoma valve, the drainage device, to reduce the IOP. But because the scleritis was severe, so they were not be able to do the Ahmed valve implantation. So we took the help of our rheumatologist friend. We started the patient on golimumab 50 mg and oral methotrexate, and the patient was given the golimumab every 4 weeks, and within 2 months we could achieve the complete resolution. And what you can see here, we could successfully implant the Ahmed glaucoma valve, and the IOP was brought down to 8 millimeter of mercury. And similarly, we presented this case also. So this is very interesting. The first case I showed you, the first case, the hypotony, we managed with biological and the patient improved. The second case, the patient had no systemic complaints. Patient had high IOP with scleritis. We treated with biological and the patient responded. And we can do the secondary procedure. So if you remember the first case, the example was if you have systemic involvement, then you should go for biologic. So ocular involvement was not the primary reason for biologic. Similarly, in the second case, the ocular involvement was the primary reason. So the model of the story is you have to choose these cases very accurately and very after discussing with patient and rheumatologist. This is very important. So there are certain side effects of the biologic. I just want to highlight one, that TNF alpha is the primary defense system against mycobacteria. So countries where the TB is endemic, one must use the biologic with appropriate precaution. Now, another, we have the Janus kinase, popularly known as JAK kinase inhibitor. So this JAK kinase inhibitor, they utilize this JAK signaling pathway, which includes the IL-2 and IL-6. These are the small molecules more likely to cross the blood-retinal barrier, and they have the advantage because it is available as an oral or tablet preparation, and very soon I think it will be available for the drop, eye drop, or topical preparation also. This is the drug which is FDA approved for the rheumatoid arthritic, psoriatic arthritis, and ulcerative colitis. In our institute, under the leadership of Dr. Viswas, we have we used it in various patients, and we found satisfactory results in selected cases of inflammation and scleritis. To conclude my talk, detailed examination of the fundus is must in any case of uveitis. Monitoring the degree of inflammation at frequent interval is very important to manage any case of uveitis, and high index of suspicion is required for the treatment of pediatric and geriatric cases of uveitis. Thank you. Thank you so much for your patience here.
Thank you, Dr. Partha Pratim, for your elegant and simple approach for uveitis in general, particularly usage of topical steroid, oral steroid, as well as immunosuppressive and biologic, particularly biologics and JAK inhibitor. This has really improved our armamentarium in the treatment of posterior uveitis as well. So it's a very good overview. I just like to ask the audience that whether there is any questions.
Hello. Okay. I thank you for your lecture. I have a good impression about the effect of immunosuppressor like golimumab, something like that. But I think the outcome of treatment marvelous, good, very, very good impression with us. But I wonder how much does this cost in India, in your country? The doses, the treatment like that, it must we have to pay a lot of money, and it's covered by health insurance a lot in your country. Thank you.
Correct. You are correct, sir. It is little costly in our country. It's almost 15,000 Indian rupee. So cost is a major factor, and but the biosimilar, for example, the adalimumab, the biosimilar has come, so the price has come down with the biosimilar, and these are the drug which you need to use in very selected cases. So I'll suggest you in selected cases you can ask the company people also to give the little discount and make it available for your patient in selected cases, and look for the biosimilars. The biosimilars are the drug with similar efficacy, but the price is relatively less.
Do you have a name some pharmaceutical company they produce your product or legal mibab, or
Golimumab.
did it come from what's the pharmaceutical company? Oh, the name.
I can if you drop a question here, I can send you the details. I can send you mail the details of these companies. Okay. Thank you.
Thank you, Dr. Partha, and it was a nice discussion as well as the presentation. So we move on to the next talk, which is none other than Professor Dr. S. Natarajan. She is the chairman of Aditya Jyot Eye Hospital, Mumbai. He is a very good speaker, well-known speaker. He was past president of All India Ophthalmological Society. He is a very good vitreoretinal surgeon. I would like him to talk on vitrectomy surgery in posterior uveitis. Over to Dr. Natarajan.
Thank you, JB. I'm really happy. Thanks for having me in this symposium. You can all hear me, Partho
Yes,
and JB?
I can hear you.
I can hear you, sir.
Okay, thank you. I'm sharing my screen. So thank you, JB, for the opportunity.
Shall I? என்ன பண்ணவா?
So today,
You paused it. Screen share play. Inga play. Inga play button. Play.
JB, thank you for the opportunity. And today is my mother's death anniversary in remembrance of my beloved mother.
Yes.
So
My
I
respect
saw my
to her.
beloved mother. So I hope you remember her. And I just wanted to pray for a few seconds and for her soul to rest in peace. So my talk today is vitreoretinal surgery in posterior uveitis, and I'm happy to be here with Vishwas. So we have already introduction by stalwarts. So severe forms of uveitis can be vision threatening, and the identification of an infectious or a non-infectious uveitis syndrome is important to determine the range of therapeutic and prognostic implications of the disease entity. And many times when you say uveitis, everybody thinks it's a medical problem, but I'm happy Dr. Bishwas has included me as a surgeon in this. So apart from treating medically, we also have uh, the oh, I think there's something you have to change the screen. No, The first report of pars plana vitrectomy for the treatment of uveitis was published in 1981, demonstrating an improvement in visual acuity in 75% of eyes in a series of 28 patients. Pars plana vitrectomy is beneficial both in diagnosis and treatment of uveitis. Among the reported benefits of pars plana vitrectomy include the removal of vitreous opacities, removal of inflammatory mediators, and the repair of retinal complications of uveitis, such as epiretinal membrane, macular holes, and retinal detachment. So anti-chamber tap vitreous biopsy helps in diagnosis. Vitrectomy enables to obtain a large volume of vitreous fluid. Vitrectomy in uveitis is unlike routine vitreoretinal surgery, and most important factor of control of inflammation. So my friend, Professor Frank Koch, had designed a vitrector, and he called it Intractor because he had a 23 gauge tip with a cutter, and it was a battery operated, and we can remove, and it was a 2-channel. And I don't know whether I have that video here, but so this is a vitrectomy in the treatment of uveitis, which is a total of 44 interventional case series published between 1981 and 2005, were identified that included 1,575 patients, and visual outcomes in 39 articles were stated as improvement in 708, 68%, unchanged in 202 eyes, and worsened in 124 eyes. Reduction in systemic medication following pars plana vitrectomy was reported in 25 studies. The median reported percentage of patients per study with CME was 36% preoperatively and 18% postoperatively. And what do we learn from this paper is, I think, in case surgery is required, we should do it early, because if you do late, I think the problem is many people don't have an unchanged vision and worsened vision. And this is the indication. There's a logarithm which shows for diagnostic vitrectomy and therapeutic vitrectomy. Diagnostic vitrectomy, biopsy, and therapeutic vitrectomy is most useful for the patient and also for the diagnostic ophthalmologist. When you have a media haze, it could be a pupillary membrane, lens related, vitreous related, and it could be complicated cataract or a secondary intraocular lens implantation. And vitreous related will be inflammation, hemorrhage, and vitreous debris, uveitis, sterile vitritis with the capro, and infectious endophthalmitis. And in case you have intraocular pressure abnormality, hypertonia, raised IOP, retinal detachment, it could be rhegmatogenous, tractional, combined, exudative, macular abnormalities like the cystoid macular edema, epiretinal membrane, vitreomacular traction, vitreomacular hole, and parasitic infection, intraocular cysticercosis, toxocariosis, caterpillar hair, ophthalmiasis, seasonal hyperacute panuveitis. Now I remember, I hope Dr. Bishwas can take out the case records operated by me from 1985 to 1988. I think we also treated rhinosporidiosis and also cysticercosis. I still remember a young boy from Guwahati who was having poke, and then he had this cysticercosis. But he didn't have much inflammation, but he had evidence of choroiditis, but patient had 6'5", N5, and post-vitrectomy also 6'5", N5. So there's a great role of vitrectomy. And malignancy-related vitreoretinal lymphoma, surgical removal of peripapillary choroidal membrane. Uveitis, an enigma. So I put myself, because I'm like this, when uveitis comes. Every time I call Vishwas, he's my rescuer for this partho. I think I also like to disturb you now and then. And a diagnostic tool, a specific diagnosis for nearly half of all uveitis patients cannot be determined. Maybe 30%, I think. I think now with the Dr. Bishwas working, maybe he can diagnose in 70%. And diagnostic partial vitrectomy may help in diagnosis, and further management may be another 10%. Indications: atypical uveitis not responding to therapy, suspected infection, bacterial or fungal or parasitic or viral or malignancy. Helps in improving media clarity and better fundus evaluation. And I still remember in 92, I think, Rupali Ingle, I think Bishwas will remember, I diagnosed as a uveitis, post-uveitic vitreous haze, and I did vitrectomy, and I saw something like a buttery mass, and I did actually little removed it and sent it to Dr. Bishwas on a routine histopathology basis, because that's what I do. And then on a Monday morning, as soon as he came to the hospital, because it was a Saturday, we couriered it, and I think he received it on Monday morning. As soon as he opened it and he saw retinoblastoma, and he called me on an emergency. He says, call the patient, start the chemotherapy, and then you send the patient for us to evaluate. And I'm happy. I sent the patient. I think that time Mahesh Shanmugam was doing his PhD in retinoblastoma. Dr. Bishwa was there. They enucleated, and the child is alive. I'm glad. I could not sleep when Dr. Bishwa was told, and then for several days, because I thought, what a grave mistake I've done by a vitrectomy. But then I realized it has been done few times. And I think McNamara also mentioned that time when he was alive. So I think we have to keep that in mind, and you should have a curiosity like Einstein when you're dealing with uveitis, and helps in improving media clarity and better fundus evaluation. Removing vitreous opacity mixed with toxins and infectious elements also helps in relieving tractional elements and better drug delivery. Indication of diagnostic vitrectomy: infectious, all of us know the endophthalmitis and all parts of endophthalmitis, vitritis, retinitis, choroiditis, and retinal vasculitis. Non-infectious: primary intraocular lymphoma, carcinoma, metastasis including leukemia infiltration, and choroidal melanoma. So vitreous biopsy, I think the procedure, subconjunctival injection with 0.1 ml of 2% lignocaine is given, poured on iodine, and then lead speculum applied, go stabilized with cotton tip applicator or conjunctival forceps. A 2 cc disposable syringe with 23 to 25 gauge needles used. And I believe that we can use this 23K intractor. I don't know whether they're making it now. I think that maybe the company is closed down. It was actually a company from US, but made in along with the Frank Koch in Germany. But I have it, and you can it has a 23 gauge needle tip, which is better than doing a suction, because I think it is risky to remove the vitreous like this. And you can see the automated self-sealing transconjunctival 23 gauge or a 25 gauge disposable vitreous cutters are available, which have inbuilt infusion and aspiration. Sterile air or fluid may be injected through the infusion syringe to maintain intraocular volume. And vitrectomy, this is a standard 3-port pars plana vitrectomy. You can do 23, 25, or 27, and you can see the infusion line. And many times, I think I learned, because we are maybe dealing with infectious, so we can do without the infusion on, and then we can collect initial, and then for histopathology or any other thing can collect it with the ringer lactate or the BSS, which you are going to inject. And then after collecting the sample, this is what is mentioned here, and the clinical yield of vitreous specimen depends on the gauge and cutting speed of the vitrector. What to do with the specimen? I think I suggest every uveitis specialist to have a collaboration with the vitreoretinal surgeon wherever they are, and also collaboration with the lab like Shankar Nethralaya. And there are many labs, but you have to find out where you are working and how you can send them. Prior coordination with the lab can help to ensure optimal handling, processing, and analysis of the specimen. The undiluted specimen is sent for standard pathological stains, immunochemistry, cytokine analysis, and antibody levels, along with PCR testing if desired. Advances in PCR methods may improve the diagnostic sensitivity of PPV and identify organisms previously not associated with intraocular inflammation. Gram stain, culture, and flow cytometry can be performed on the diluted vitreous sample. When considering diagnostic pars plana vitrectomy, primary intraocular tumors such as UL melanoma should be excluded from the differential, because inadvertent extraocular extension of tumor cells has been reported from the sclerotomy times. sites. While chorioretinal biopsy was initially performed using a transclear approach, pars plana vitrectomy has gained favor due to its reduced risk of retinal detachment as well as vitreous and subretinal hemorrhage. Chorioretinal biopsy may be indicated when there is a disease process limited to the choroid and retina with minimal vitritis and can be helpful in the identification of exclusion or intraocular malignancy. And pars plana vitrectomy should be performed with separation of posterior hyaloid at the site of biopsy. The superior temporal quadrant is preferred for chorioretinal biopsy as GAT tamponade is more facile in this location for prevention of iatrogenic retinal break. Vertical scissors or a diamond blade are used to excise a 1 millimeter to 2 millimeter square portion of the suspicious retina and choroid after marking with diathermy. The specimen is removed through ports. The endolaser barricade is applied all around the biopsy site, followed by gas or oil for tamponade. Sometimes I do the endolaser barricade and then do the biopsy. Temporary elevation of intraocular pressure to about 70 millimeter of mercury may help to minimize intraocular bleeding after excision of the specimen. But I think we should keep an alarm at 59 seconds, and I don't like to cross 1 minute and bring back the pressure. Maybe you can give a gap, the optic nerve perfuses, and again re-inject, but I think don't keep the pressure high, because I remember this is what I learned from Dr. Vaidinath. What is the point in arresting the bleeding and having a disc pallor? And patient is diabetic, where even 30, 40 can make a disc pallor. And we are always generally seeing post-vitrectomy in diabetic for any indication, they have a disc pallor. In recent years, the use of 25-gauge vitrectomy has been reported for successful chorioretinal biopsy. A clinical suspicion of lymphoma or malignancy, this is using the undiluted sample, smear using modified right game sustained, PCR for gene rearrangements in the variable region of the heavy chain of immunoglobulin or the gamma chain of the T cell receptor, MYD 88L265P gene mutation testing we have done and published along with Bishwas and Dr. Pukhraj Rishi. Cytokine assay for interleukin IL-6 and IL-10 if indicated, and diluted sample, cytology analysis of papinocular stained slide. In case of sufficient sample, centrifuge sediment embedded in a cell block for special stains, periodic acid shift, immunochemistry analysis, and flow cytometry. And I think the uveitis specialist and the surgeon should know about this, because I once remember Dr. Vajana took me to the lab to say that you come on, put it in the petri dish as well as also inoculate into the media. And I think I was struggling. And after that, I know that I worked in the lab as an intern to learn what they're doing. We may not be able, need to do it, but I think you should know what they're going to do. And clinical suspicion of infection, undiluted sample, again, smear, gram stain, KOH mount, PCR, and diluted, you have culture analysis, bacterial and fungal culture, and for antibiotic sensitivity. So therapeutic vitrectomy indication, and this is where many times I think I recently had a patient who went from Jaipur to Delhi and maybe many places, but I don't know why they didn't plan a vitrectomy. And I think it was just a media opacity, vitreous opacity. But I think after that, the patient calls me God. But I think the treatment was done elsewhere. I just operated the sequelae, and patient gives me all the credit. But I think we all doctors have to work together, sometimes as a thankless job. I think if you do your duty without attachment, you will enjoy doing it. And endophthalmitis, lens-induced uveitis, inflammatory control, manage complications like aparietal membrane, retinal detachment, cystoid macular edema, and raised intraocular pressure or hypertony, and control of inflammation using a cover of systemic steroids with or without immunosuppressive becomes mandatory in perioperative period. And uveitis is the media haze. Sometimes they have a small pupil. So I use the wide angle from 90, that means 31st year now. And I'm glad most of the world I taught how to use wide angle. You can use a small non-dilating pupil without touching that. And a pupillary membrane, complicated cataract, dense posterior opacities, thick membranes, and vitritis. Small incisions are preferred to avoid intraoperative opacity or intraocular pressure fluctuation. Often viscoelastic may viscodissect the iris and anterior capsule of the lens, and injecting cannula may be used to break the adhesion. You can also use the iris spatula to break the adhesions and making without traumatizing the pupil. In severe plaster iris and a rigid pupil, pupilloplasty is an option. Thick pupillary membranes need to be removed with a vitrectomy cutter or peeled with a microforceps initially to allow clear fundus visualization. In phakic eyes, surgical total anterior capsule may be carefully avoided to plan lens pairing in case lens is relatively clear. And this is a aparietal membrane peel. and you have inflammatory cystoid macular edema, sometimes you can use the vitrectomy for a recalcitrant CME, and you can actually do a stain with the brilliant blue and remove an ILM and just leave the eye. I think the CME can resume, and which is refractory to medical therapy. I think can do the sometimes long-standing macular edema not treated with the steroids and with the uveitis, you can develop macular hole. I think you should have manage this well. So my suggestion will be to prevent. So explain to the patient, if you don't treat the macular edema with the anti-VEGF or steroid and or with the Ozurdex, and I don't have any financial interest, I think you can land up in macular hole. We can prevent it. So conventional vitrectomy, ILM cleaning, and you can see here vitreomacular traction with the macular hole, and this is a post macular hole. You can see the OCT on the epiretinal membrane traction, and then you can see it's a post vitrectomy removed, and then you also have a macular edema, which you can give even intravitreal triamcinolone. And uveitis was found to be an independent risk factor for rheumatogenic retinal detachment, particularly in CMV, ARN, and PORN. An acute retinal necrosis, and I remember we were operating a vitrectomy for acute retinal necrosis because they end up in multiple breaks and retinal detachments and silicone oil, and that is in 1986 when silicone oil was we just started using in Shankar Nethralaya. Otherwise, we were removing oils, and most cases are unilateral, and about 1/3 of patients present with bilateral acute retinal necrosis. And I remember there's a Japanese author whose name the syndrome is associated when Orayama, I think. And then the post-vitrectomy visual acuity. Orayama. Thank you, JB. I think you were working with me that time, or rather I was working with you that time when I did that syndrome. And then following that, I think Dr. Narsingh Rao invited me to Japan for the first sympathetic ophthalmia group. And thanks to you, I got to know Professor Narsingh Rao. And silicone oil is used as a tamponade. And PORN syndrome is a devastating disease caused by the varicella zoster virus, a form of ARN that occurs in AIDS patients. And again, thanks to Vishwas for teaching me, I started doing the first one probably in India to do AIDS patient vitrectomy those days in 90, I think. And I think Aditya Jyoti Hospital was a pioneer. Thanks to my OT staff. They're all alive and they're working with me. And I remember Dr. Narsingh Rao gave a first lecture in Bombay, and then later Vishwas has come and done lots for the AIDS. So, and I'm happy that with all the treatment, AIDS patients are not seen much, and there are a lot of people who are taking care of them. And surgical repair and retinal detachment, you can see 360-degree retinal laser done, and we can see the retina attached. And I remember many eyes, we can save the optic disc, macula, and some amount of retina, the patient will bless you. And you use a perfluoride liquid as a third hand. I'm glad I introduced that in 91 after attending the first perfluorocarbon liquid meeting, thanks to Professor Raja Jovanovic, my second mentor after Dr. Badrinath. And parasitic infections, and I think you have protozoans, toxoplasma retinochoroiditis, and toxocariasis. And also you can see the toxocariasis showing the toxocariasis granuloma with the epiretinal membrane, and we can remove that, and you can see the laser marks, and then the fundus photo post vitrectomy. Intraocular cysticercosis, my favorite, because many times you can get 6.6 and 6.5 N5 vision, and I'll have a video to show. And most common is pars plana vitrectomy, and this is a 20 gauge that time, 92 I think this is a vitrectomy done, and you can see the 3-port pars plana vitrectomy. I'm now doing the anterior vitrectomy, then mid vitrectomy, and posterior vitrectomy. And that time I always use the wide angle observation system, the biome. You can see this is a chorioretinal scar which was there, and probably the patient had a subretinal cysticercosis, and I think, I don't know how they come in through by separating the cells and not making a hole in the retina. And I'm amazed how these cysticercosis work, and I'm now use shining light just to get the scolex, but it wriggles, and I used to put the snake charming music, and the entire Europe can never forget this video, and you can see it wriggles now by just because of the stimulating that with light. And I think this is and I made my own technique where I like to remove the the cyst in toto, even though there are reports you can cut and remove. At present, I'm using the suction without activating the cutter. It is quite risky because if you accidentally on the cutter, you can cut the cysticercosis. So what you have to do is do a good vitrectomy, and then after that, leave the cysticercus, toilet the sclerotomy, and there's a 20 gauge sclerotomy, and no need to expand the sclerotomy. That means no vitreous is there in the vitreous base excision is done around the sclerotomy, and then use the suction. The cysticercus makes as a dumbbell or a 8 shaped, and you can see the entire cysticercus comes as a whole, and then you can complete the vitrectomy and just make sure there's no vitreous adherent to the chorioretinal scar. The idea is not to leave behind some vitreous which will act as a scaffold. And I think I overdid a laser at that time, thinking there may be break. Then I realized there's no break caused by cysticercosis coming from supranatal space into the intravitreal space. And I think this is in the beginning of my experience with the cysticercosis. And this is a vitrectomy in a case of old healed with a viral retinitis. This is what I mentioned. The treatment was done very well by the 3 ophthalmologists. And probably like Bishwas, the patient has not been counseled long enough. That means the surgeon talks or the consultant ophthalmologist uveitis talks, then I have an executive nurse who actually counsels the patient, and then I have a retina fellow talking. That means so many people are examining already, like optometrist, then the fellow, and then I see, and then after that again, post I advise the patient, I speak sometime, and then the fellow, and then and I now call it, after reading the book, Compassion and Medicine by first Dalai Lama Rinpoche. So I'm writing a book. I hope I'm writing Miss Aishwarya Iyer is the fellow who should write. She's here. So I'm showing her here. So I hope she read Dr. Natarajan's Compassionate Eye Care. So this patient, 65-year-old nice lady, who's from actually Rajasthan, but went to Delhi, then came with so much frustration that doctor, I have taken so much medicine, so many doctors, and you are the 4th or 5th doctor. Can you do something? And it was a case of healed herpes simplex virus viral retinitis, which was 2 years treated, presented now with complaints of severe floater interfering with her vision. Actually, her vision was, I think, almost 6/9. And only the problem was this hazy vitreous moving here and there. And on examination, multiple course floaters and vitreous debris, no active retinitis lesion. Treatment we planned was vitrectomy and a vitreous biopsy. And I sent the specimen to Dr. Bishwas, and as usual, he gave the negative and present the patient. This was on the 15th December, we had done the vitrectomy, and this is the red-free photograph, and you can see the peripheral retina, and then you can see the surgery. So I do a 3-port 25 gauge pars plana vitrectomy. I'm glad I introduced this. I introduced minimal invasive vitrectomy surgery, MIVS, first time in the India, with Mark Humayun coming from, who's a good friend of Bishwas also, who's a pioneer in artificial retina. He came and introduced the 25 gauge. That time I had Bausch and Lomb, no financial interest. And you can see I do 3D vitreous surgery, and we cannot show the 3D now. And I'm glad I'm one of the authorities on using 3D vitrectomy for which I do only that now, so that I do daily and I really enjoy. So I sit back like a Maharaja and operate, watching the 70 mm screen, and which is really, I think is exactly like sitting inside the eye and clearing using a mop or something, or sweeping the floor. And that's what I get the feeling. And I'm now completing the peripheral vitrectomy as much as possible, because you can see without depression, and you can see some cloudy vitreous, which I'm again trimming it. And I made the eye clear, and the patient is quite happy. Even I just put air in the conclusion. So, and you'll be seeing I'm just examining the periphery to make sure there is no vitreoretinal traction, and making sure that you use high cutting rate. I use 10,000 cuts per minute, and the suction I sometimes keep at 500, but I don't recommend for the regular surgeons who are not experienced to keep the suction low and high cutting rate. The idea is so that the little amount of vitreous will come. It may take a few more minutes. I think the time is not the constraint. I think you have to have every movement useful. That means every activity, that's what I learned from Dr. Badinar, catching the conjunctiva or entering the eye or doing the cutter. And it looks like that for a non-vitreous surgeon, like a medical retina specialist like Bishwa, that I'm working in the just empty area, but I am actually looking for the vitreous and doing it. And that's why I'm not forwarding the video, just to say that you make sure that every part of the vitreous is removed, and then you can check. You can also use steroid, and that's the conclusion. And I think it looks like I have not even injected air. I think the idea was just to leave the eye so the patient will be happy the next day that she can see. And I think that's what happened. A patient called me God, but I'm not. I'm only a servant of God. So thanks for the opportunity, JB and Partho and Dr. Sheila John and Shankar Netralaya and APN. The vitrectomy represents a critical tool for the appropriate diagnosis of the underlying cause of intraocular inflammation. We are in the 51st year of vitrectomy after Dr. Robert McNamara did in 1971, as well as a therapeutic option to restore vision for patients through removal of media opacity and restoration of retinal architecture. And I think you can restore even 6.6 and 5 in many eyes, if not in all. And use of smaller gauge. And that's what I remember Dr. Charles Keepan saying, do the least to reattach the retina. And that's in the 2-volume big book is written. So the same thing holds good for uveitis. Inflammation should ideally be controlled prior to vitrectomy, and the multiple indications for vitrectomy in uveitis, heterogeneous nature of uveitis disease, syndromes, and adjunctive therapies present challenges for clinical trials and are opportunities for further investigation. I thank for the opportunity for this. So thank you, JB. And I thank Dr. Aishwarya here and my secretary, Shubha. Thank you, JB.
Thank you, Natarajan, for this illuminating talk and giving an overview of vitrectomy and posterior uveitis. And we need to have a vitreoretinal surgeon in the team. Uveitis cases, a lot of times for the diagnosis purpose, for the treatment purpose, for the complication purpose, we need the assistance of the vitreoretinal surgery. For the sake of time, I'll go to that last talk, intraocular toxocariasis. And this will be done from Vietnam, Dr. Huan Quang. So I invite Dr. Huan to talk on the intraocular toxocariasis. Thank you, Natarajan. Thank you, Nati. Dr. Huang.
Thank you, JB.
I started to learn now. Okay. First of all, I would like to say thank you, Dr. Zietoti. Maybe this was Dr. Primary who inviting me in this conference. I have something to talk about surgical management of toxocariasis. In case of retinal present in Vietnam, we have some case. And I think you are all good expert in this sector, so I should go fastly. I think like that. I have an introduction to toxocariasis causes dermatosis. We have a two characteristics, less frequent than T cati. And in a systemic disease, toxocariasis disease is cell-limited. It happened with children with a 6 month and 4 year old. We can general sign like eosinophilia, hematomegaly, infiltrates in the lungs. In case of ocular toxocariasis, it happened with children and young adults also. Important causes of uveitis and visual impairment during your childhood. Prevalent in Ireland, they have some statistics. Japan 1.1%. In Vietnam, 3.2% uveitis. We do some summarize in our hospitals. And average age SEL normally typically it's happened we need NATO visual impair leukocoria strabismus and so. And in clinical side, we have a peripheral granuloma, posterior granuloma, lemmatous endodermatitis, and atypical presentation and so like that. We have some image, some photo. We get first photo of the peripheral granuloma. second for fibrocellular band, quite density and opacity in vitreous cavity. In the scale of a posterior granuloma, we image quite typical. We do OCT at that side, and we found that subretinal granulomas inside. Ocular toxicology risk in case of nematodes, endophthalmitis, the type APAN uveitis, possible severe ocular inflammation with hypotrophic posterior silicia. And we found that in the fundus granuloma, retinal, quite difficult to observe, and normally it happens in younger eyes. How about the histology examination? Is the demonstrate lava quite rare, but in the clinical hematology imaging diagnostic serology step, we can diagnostic that ELISA test we do which serum patient, and histologic information we collect the same specimen from aqueous humor and vitrectomy sample also. So this month so far we do the medical treatment in active inflammation phase. We apply the topical systemic corticosteroid to reduce the vitreous reaction, to limit the membrane formation. And we use enzymatic therapy here, mebenazole, mebenazole, quite popular here, 200 milligram per day and in month. In week general disease or systemic disease, we have to take a longer treatment with 400, 800 milligram per 2 weeks. And it came up, we found the lavage subretinal. We do the photocoagulation. We use anti-VEGF also in we found that CNV. Small surgical therapy, I mean that's PPV, papapanana vitrectomy. In the indication should be a retinal detachment, retinal membrane, vitreous opacity. Well, two patients, first 33-year-old, we do the research group about 33 eye of a patient, meaning we found that 13-year-old and baseline visual acuity very limited, quite poor, count finger to 20/100. The indication for PPV, we can see here we have a person retinal detachment, epithelial membrane 5, vitreous opacity 1 case. We do PPV with a wide angle view system, biome we call that, and with some case we endoscopies. And so after 1 year follow-up, visual acuity post-op, count finger improve something with some case 20/60. Anatomic reason I think quite fine, okay, or retraction, retinal 70% retinal membrane 100%, vitreous opacity 100%. And we have some complication on retinopathy 3K, cataract 4K, glaucoma 2K. It's due to the silicone eye. 1K illustration, 25-year-old female, blur vision within 1 month, OD 20/50, whereas the count finger, anterior segment, nothing special. plus that makes me normal. And we ELISA, we are positive with Tosokaro. In this case, we do the PPV with the biome system, wide angle system. I'm not expert in this field, but I think elaborate or retraction. You know, with this case, one time follow up, left eye cut finger 1 mat and cut finger 4 mat after 4 meter after 3 month follow up. Whereas the second case again, 20-year-old, blood vision 1 month, as 20, 160. He has anterior chamber with inflammation cell, carotid with precipitation, virus, highs and cell, and ELISA test positive, keratosokara. The ultrasound, and we saw some retraction from the retinal virus. Basically, quite complicated because the time point and clinical site were up and down. And the treatment, we changed something, but quite limited because the weapon to deal with this case was quite limited on way PPV and Medron, some eye drops and so on. In this case, we do PPV with endoscopic system. I think that in the endoscopic system, we can focus on lesion, but we cannot have an overview around that, so it's quite disadvantageous. As a conclusion, ocular toxocratis is a common infection in children and young adults in Vietnam. You know that we eat fresh vegetable or fresh meat, raw meat, also in some region in Vietnam. This is important impairment is visual acuity is caused due to retinal complication. And when there are some retinal complication, we do the surgical treatment. PPV it should be considered presenting of stability or improvement of visual function. I thank you for your attention.
Thank you, Dr. Huang. It's an excellent talk, and giving that one of the rare conditions and vision-threatening disorder, the toxocariasis is quite a challenge. We do see these cases in India also, and surgical treatment is sometimes quite gratifying, but may not be the total improvement of the vision may not be possible. So the two cases are quite interesting. I just want to ask the audience, is there any questions to Dr. Huang or any other speakers? Anybody in the audience? I don't know where that comes. Anybody has got questions on any of the topics? I think then we'll conclude. I'd like to thank all the speakers, Dr. Parthapratim, Dr. Natarajan, Dr. Huang, and Dr. Sheila Jan, who organized this meeting. I'm quite thankful. And Dr. Sheila will have some concluding remarks.
No, sir.
Let's take one more.
Thanks again. Wow. I hope to see you later in the future. I think very usual we got. Okay.
I'd like to be in Vietnam physically.
Okay. I by myself, I visit Madurai, IRIMS System Hospital. I have a training course in that. I went to Gaya one time, and I learned from you a lot of things. And highlight your country, your culture. Thank you.
Thank you. Thank you. We conclude. Thank you, everybody. Thank you.
Thank you, everybody.